Okay, so it's past 7:35. I'll get started, and then hopefully we'll have more people joining later for the discussion. Good evening, all, to this weekly huddle. My name is Anup Agrawal. I'm an interventional cardiologist. I think today we have our regular audience, so we are not going to go through the entire introduction part. This is our 37th session. And the topic that we chose for today's discussion is resistant hypertension, something that we see very often in our clinical practice. So having said that, I'm directly going to go with the clinical case for today. And then I will ask Praneeth for his input. And then we'll take the opinion of other attendees. So, Praneeth, this is a patient I saw, I believe, 2 months ago, and I'm going to present it to you as if he's coming to you for today's visit. And you tell us how you would manage it, and then we will open it for discussion. So, this is a 55-year-old male. He's a banker by profession. He was diagnosed hypertension for about 10 years ago. And now he's coming to see you for the first time. He leads a routine life. There are no active symptoms. He's not very active. He minds his own business, but there is no any dedicated exercise of any form. He's not having any symptoms. He lately started recording his blood pressure at home because somebody gifted him a BP machine, and he said might well just start recording. And his home reading typically revolves with systolic around 150 to 160. And diastolic, he gets in low 90s, like somewhere between 88 to 94 typically is what he runs, with occasional erratic numbers here and there. He mostly checks his blood pressure in the evening, but sometimes he checks it in the morning as well. Further history, his brother had a PCI done when he was of the same age as our index patient is. His brother is around 5 years older than him. So otherwise, he's fine. He brings a master health checkup package done with you. And he has got this 25 pages of all the reports. Everything else is normal, except his ECG showing high voltages. And his echocardiogram had got LVH with a septal measurement of around 12 millimeters and a grade 1 diastolic dysfunction. He remembers getting a renal artery Doppler scan done about 5 years ago, and that was reported normal. Other than that, all the routine investigation, including thyroid, HbA1c, and his hemogram and whatnot, they have all been normal. On his examination, his BMI is 28, so he would fall under overweight category. His blood pressure in the office when you measure is 164/94, so that is higher. His heart rate is 83 and it's regular. The rest of his exam is okay. I'm not going to get into the details of that. His current medication is telmisartan and a chlorthalidone fixed dose combination drug with the doses of 40 milligrams and 12.5 milligrams respectively, which he takes in the morning after breakfast. He's also taking Synod, which is cilnidipine, 10 milligrams twice a day. He takes one along with the morning dose of telmisartan and one in the evening. And he also takes a multivitamin daily. So he comes to you, he says that, Doc, my blood pressure has been a little bit high. I have heard that normal blood pressure should be 120/80. What should I do to get my blood pressure better? And how would you evaluate this patient? What all things you would like to know or do in terms of history or exam or investigations? And how would you go from here? Praneeth, if you need any specific answers for this case, please feel free to ask me. All yours.
Yeah, good evening. Resistant hypertension, but I have my doubts or concerns before I label the patient as resistant hypertension. I believe most of them are so say that say that most of the income with drug or measurement of the BP are erratic, and the second other can do the resistant hypertension like using the NSAIDs or using nasal is in the alpha blockers. alpha blocker, which will increase the hypertension. So first, I will make sure that these things have been taken care of, and second thing, do measurements on both the limbs and upper limbs, and try to make sure that the measurements are accurate, and having the diagnosis of resistance hypertension itself is being made, I try to look at those probable causes which could lead to it. And the question first would be, how do we evaluate and how do I treat this patient? So for we talk about resistant hypertension, the first thing that comes in mind is renovascular hypertension. So I would try to look clinical examination whether he has any renal bruit or any abdominal bruit or any other vascular bruits heard on the other vascular territories. Try to find. And other thing is, I would try to look at evaluation of renal artery stenosis. So I would advise him to get a renal Doppler done again, though it was normal 5 years back. I would try to look at his electrolytes, try to find whether there is any hyponatremia, hyperkalemia, which might suggest a possible endocrine causes, and that would be the evaluation of resistant hypertension. And regarding treatment change, now that he is already on the three ABC of the drugs for hypertension, that is the ACE inhibitors, ARBs, diuretics, and calcium channel blockers, then I would put him on a fourth drug. Because he is on ARB, I would try to look at his renal functions and serum potassium, and if they are in the normal range, I would start this patient on melanocorticoid receptor antagonist, preferably spironolactone or eplerenone. Preferred drug would be spironolactone because of the use and comfort which I am, and try to monitor and try to look at other issues. If it extends, because the BMI is high, I would also try to look into evaluation of obstructive sleep apnea syndrome, try to take some history suggestive, and if that again, because of the availability and the practical issues of getting a sleep study done, I would be tempted more to advise them a trial of CPAP than getting the sleep study done. Wherever possible, I would do advise, but still I would advise them a trial of CPAP, which is more comfortable getting done than the sleep study. So that is my take on this case, Anup.
Thank you so much, Praneeth. Praveen, if I can have you on board, I have 2-3 questions for you, and then I also want you to weigh in on the clinical case. So going back to what Praneeth said, checking blood pressure in other limbs. My question to you is how frequently you end up doing, or you see people doing, where they check all 4 limbs, upper limb as well as lower limb, or even check on the other hand as well, let alone on the legs. And if you do need to check blood pressure of the legs, how do you do that? And second, patient got an arterial duplex done 5 years ago, which was normal. Would you care to repeat the test? And third, what is your thought about sleep apnea and hypertension? So if you could just weigh in about the case and then the questions that I addressed. Praveen.
Okay, sir. Good evening, everyone. Regarding the case scenario, if the same patient has been seen by me, I would ask when would he check his blood pressure in the home. Most of the persons, they check in the morning. You said this person was checking in the evening, and having said that, what you call most of them, what you call check the BP blood pressure just after the tea and all that, because they attach it to some kind of work so that they don't forget. But most of them don't follow the usual protocol of checking adequate method of blood pressure monitoring. Some of the persons which I follow up, they place the cuff reversely, which would not be placed directly over the artery or anything. So that I would be asking, sir, and then see whether it is what you call correct in that aspect or not. Next coming, if everything is correct and the patient is compliant with the medications, ambulatory blood pressure monitoring, sir, if it is comfortable, and then high blood pressure recordings, then I would see when it is the frequency, whether it is in the morning or the evening, and label the patient as resistant hypertension, and then work for the in the protocol of the resistant hypertension. And most commonly, again, renal vascular disease is to be suspected. Clinically, I would be seeing, and then as the Pranit sir mentioned, the same one I would be seeing, sir. Now, coming to the 3 questions you have asked, sir, strictly speaking, only if the patient blood pressure is high and the patient is what you call clinically stable, then there would be a chance of recording the 4 blood pressure, sir. Otherwise, there is no chance that all the 4 blood pressures will be monitored. Having said that, the other technical issues, sir, in most of the hospitals, we don't have the adequate size for the thigh, or what you call, sorry, for the lower limbs, and those patients who are obese. So the same cuff size will be used for all. So there is a lack of the availability of the cuff size, and as well as most of them will not be checking all the 4 limb blood pressures, even if the patient blood pressure is high and patient being stable. I mean to say, patient is having just hypertensive urgency rather than an emergency, where you'll be just concentrating on stabilizing the patient. The next case scenario would be is checking the blood pressure in 2 limbs. That also no, sir. I would say probably if what you call, if we have time and make a time, we would be checking in both pressures, but I would say that most of them will be checking in only one, and we often see that we will be checking the blood pressure over the shed rather than what you call on the bare arm. And the usual tendency in Indians would be what you call, as soon as the patient comes into our room, we'll make him stabilize, but we don't see what his scenario and all that. We don't ask whether he has had a cup of coffee or tea, then check his blood pressure and label it as he's having high blood pressure. So those should be taken into consideration, sir. Now, coming to sleep apnea, in Indians, what you call sleep apnea is more common, sir. So taking the history of snoring and all that would be adding value in controlling his blood pressure. I think I have answered all the 3, sir. Hello, sir.
Yeah, Praveen, thank you. We have been hearing you. Thank you so much. Let me ask somebody else for his opinion. We have Dr. Prithvi with us. Dr. Prithvi, I hope you got the clinical case. We are talking about a 55-year-old banker who is having blood pressure of around 150s to 160s over 90s, both at home and at your office as well. He's taking 3 medications. 5 years ago, his renal ultrasound was okay. His today's master health checkup, whatever comes in that, is normal except some left ventricular hypertrophy. How do you handle these kind of patients since the blood pressure is suboptimal? It is more than 150 and diastolic is more than 90. Or you think this is an acceptable blood pressure to work with? If the patient comes to your OPD, how would you start and what would be your assessment? And I also want to know, how do people check leg blood pressure in their office? I'm curious to know how we do check lower limb blood pressure. Dr. Prithvi, if you could unmute yourself and share your thoughts with us. Dr. Prithvi, we are not able to hear you. Your voice is breaking. Dr. Prithvi, will it be possible for you to come at a more stable network?
Okay. Now I'm audible, sir?
Yes, you are much better now. Yes, you are much better now, Dr. Prithvi. No, again there is noise.
Now it's clear.
Yeah, no, there is a lot of noise, Dr. Prithvi. We can't hear you. There's a lot of static in what you are saying. Will it be possible for you to disconnect and then reconnect? Hopefully, you will get a better signal while we talk to other attendees. There is a lot of static in your voice. Don't mind disconnecting and reconnecting again. We have Dr. Kirti with us. Dr. Kirti, if you could unmute yourself, give a short introduction of who you are, and then tell us about your approach to this case and what would you do if this patient comes to your OPD. Dr. Kirti. Dr. Kirti, we can barely hear you. Your voice is very low. It is the quality is okay, just the quantity is low. It's very low volume. Dr. Kirti, we are not able to hear you. Is anybody else able to hear Dr. Kirti? Praneeth, are you able to hear Dr. Kirti?
No, nope, I'm not able to hear.
Yeah, Dr. Kirti, your voice is very low. I think you may have to come very close to the mic. No, I don't think we are able to hear you. Dr. Kirti, your voice is very low. Okay, I'm going to mute you. If you could just get onto a slightly better network. Let me get back to Dr. Prithvi. Dr. Prithvi, would you want to try again? Let's see if you get a better signal this time. Dr. Prithvi, whenever you can hear me, you can unmute yourself and share your thoughts with us. So while we get some technical issues sorted out, Praneeth, let me ask you a few questions. In our care OPD, you can just keep yourself unmuted, Praneeth. We'll probably engage in a 5-10 minute dialogue, and then I'll invite other people to share their thought. So in our OPD, how do you check lower limb pressures?
So the same blood pressure cuff which is there, I tie it to the cuff, and because we have this automatic machine, I press it, and that is how I take the measurement. Understanding that this is not the accurate measurement, but at least I have some number and try to correlate with the blood pressure measured in the upper limbs.
So that is the calf pressure you are taking, I'm guessing, right?
Yes, cuff pressure.
And the calf pressure you are taking is when the patient is lying down, I'm guessing?
Yes.
And the arm pressure was taken when the patient was sitting up. So what do? You make them lie down and then take arm pressure again?
Yes. So now that the patient is lying, do measurement once in the both the limbs, and then do the same thing at the one of the legs and do the calf pressure. And I have 3 readings of 2 upper limbs and 1 lower limb.
And what kind of cuff size you are talking about? Because I don't know if the digital machines are able to accommodate the cuffs.
Yeah, sometimes the legs are huge where the that cuff is not completely encircling, where I can't take the measurement, but most of the times I'm able to put that BP cuff, which is the standard one, which is available medium to large, which is there for most of them, and that is the same thing which you use it for the cuff.
And can you fathom, is it any way possible for you to take a manual pressure of the leg?
Manual again is the same concept, the same cuff you apply to the cuff, because I don't find that large and extra large cuffs anywhere. So use the same thing which can reasonably encircle uh, the limb and compress the vessel and give it pressure measurement. So what I used to do in my post-graduation days is use the same BP cuff. They apply tight over the calf and use the dorsalis uh, as the reference to check the blood pressure.
So you are doing a palpation method, so you're only getting systolic, right? There is no way you can auscultate that area, correct?
Yes.
Okay. And my second question is this obstructive sleep apnea business. What do you think, or what have you seen about patients with higher blood pressure whom you diagnose sleep apnea, and when you put CPAP on them, do their blood pressure actually improve?
Not much. Basically, the complaints with sleep, that CPAP is also an issue. Firstly, we don't have a reference of diagnosing it. It's more of a clinical diagnosis. I do want to get a sleep study done, but the practical issues is what helps me not getting it done. So when the symptoms are suggestive strongly that obesity, some snoring, daytime somnolence, some associated hypothyroidism, where the possibility of having sleep apnea is high, I do ask them to take a trial of CPAP. Some do feel better and they tend to continue, but most of them, again, there is an issue of compliance where the maximum usage of the CPAP is hardly for 1 or 2 months. And with that, did the blood pressure come down? Not much. But I believe with the long-term usage of CPAP, it might reduce. But my practical experience, the whether did CPAP make any difference, I would say no, because the limitations being usage, the man hours, if I have to say, in the usage of CPAP is very less.
Okay, all right. Let me see if I can invite other attendees. Dr. Kirti, do you want to try one more time? Let's see if we can hear you slightly better. Your voice was very feeble last time when you tried. Dr. Kirti, if you could please unmute yourself and see if we can hear you. Okay, maybe I'm not able to hear you. Dr. Prithvi, you want to try? You want to unmute yourself and see if we can hear you slightly better?
Hello. Hello, sir. Am I
Yes,
audible, sir?
Dr. Prithvi. Yes, you're audible, loud and clear. Pretty good.
Yes. Sir, if that patient comes to our clinic, so first I would like to ask him about his adherence to the medication, sir, present medication. So if he's taking present medication correctly, and then dietary modification is following, like salt restriction and any lifestyle habits like smoking and alcohol is restricting them, or what? First of all, I will assess that, sir. Then secondary, if any other symptoms like what seniors are told, like history of snoring and daytime sleepiness, I would like to assess, because OSA is more common in our Indian population. And any other medication like NSAIDs for any painkillers like that is medicines which might increase the BP. So I would like to assess. And finally, any increased stress recently because of any family issues or financial issues, because stress also is an important factor for this hypertension. So I would like to assess like this, sir. Sir, I'm audible? Hello?
Yes, Dr. Prithvi, you are audible, and you brought up a few points that I think is worth discussing amongst us. So thank you for bringing those points. And if you have anything else to add, you can either put it in the chat box or you can raise your hand. Let me get on the discussion. So, Praneeth, few points are brought up by Dr. Prithvi again. I would again ask you, this alcohol and smoking, is it really a villain in BP control, or is it more of a trend to tell patients to do the right thing? Are we using BP as a scapegoat to tell patients to do the right thing? Of course, not smoking and not drinking is the right thing, but is it related to blood pressure? What is your thought?
So smoking, yes, I agree that smoking increases blood pressure because of we have data to suggest this thing. So smoking, definitely yes, that smoking increases blood pressure, and particularly when we are measuring blood pressure after a smoke that the patient has, it can definitely lead to rising blood pressure. Regarding alcohol, my take is that if the intake of moderate alcohol is moderate, probably it is a bit kind of controversial where there are some beneficial effects and there are some harmful effects. But my take is on the company that it keeps. Like alcohol, when is consumed, the munching which happens, usually the intake of food items which is taken along with the alcohol are high in salt intake. They are usually spicy, salty. That is what I believe contributes to the rise in blood pressure and probably that resistance to the medication. So I say whenever you are taking alcohol, try to limit the amount of alcohol, but equally be mindful of what you are eating. Most of them are the mixture or the namkeen or the items that are consumed are usually deep fried and salty, and that probably I believe is the culprit for the rise in blood pressure rather than alcohol alone per se. So that is what I tell my patients to equally watch what they are eating while they are consuming alcohol.
Okay, I have one more question for you, but I would also ask my attendees. Dr. Prashant joined us. Dr. Prashant, may I request you to just look at the chat box? I have put in the case summary for you to review. I will ask you about your opinion. And I would request Dr. Vrinda to do the same thing. Vrinda, I'm going to come back to you. I'll come to you rather with this case once I'm finished my discussion with Praneeth. So Praneeth, my other question is, history of snoring. So this patient comes to you and if he says, I don't snore and my daytime symptoms are okay, do you still test for sleep apnea or you give it a pass? Like what is the negative predictive value of no OSA symptoms?
So the snoring thing, I get reminded from Dr. BSR, which I learned that snoring is something which people never complain because they don't know, and the best way to know whether the patient is snoring is ask the patient. Patient attender or the partner who is sleeping, provided they are awake to notice or their sleep is getting disturbed because of their snoring. So this is what I learned and I still practice where I'll ask the person who is the partner who is sleeping whether he snores, and some do agree or they do give the history of their snoring. So that is my take on the symptom of snoring.
So that is good. My main question was with regards to, let's say if you have a true history of no snoring, partner says there is no snoring. And the patient says, I don't have daytime somnolence, I don't have early morning headache, I don't wake up with dry mouth, and all the other symptoms that you typically elicit for OSA. Absence of symptoms, does that give the patient a clean chit for not checking for sleep apnea is what my question here is.
No, so if the resistant hypertension is there and I'm not able to find a specific reason, and if there is a suspicion of this resistant hypertension and there is a possibility of obstructive sleep apnea, even though he denies all these symptoms, I would still say it is worth checking for obstructive sleep apnea, and I would advise them to undergo sleep study.
Perfect. Thank you so much. I'm going to ask Dr. Prashant to weigh in his impressions about this case. And we did discuss about taking history of snoring, checking for sleep apnea, the question of whether we should repeat the renal ultrasound or not, and the 4-limb blood pressure check, as academic and as fancy as it sounds, practically, how do we check it? Do we really check it? And what kind of information are we looking at it? So, Dr. Prashant, if you could just share your thoughts on this case.
Good evening, sir. Sorry I joined late. So if this is a case of resistant hypertension, and first thing we should also check about compliance, whether the patient is compliant in taking all the drugs. If he is compliant, and if we are following the routine of giving the 4 drugs, which includes a diuretic, then maybe we can add an aldactone. And I think most of the things you told, you have ruled out, like renal artery stenosis and OSA, and that's all, sir. I could not find anything else.
And Dr. Prashant, how would you check lower limb blood pressure? Somebody said that when the patient comes, we'll check 4-limb blood pressure. Do you find any utility, and how would you check it?
Yes, sir. 4-limb blood pressure, upper limbs is okay. Lower limbs, if we are checking the upper limb at the arm, at the where we check the upper limb blood pressure is also important, because that should be corresponding to the lower limb blood pressure. So lower limb blood pressure, we can check it at the ankle level. If we have appropriate size cuff, if we don't have appropriate size cuff for the thigh cuff, so we can apply the same cuff sometimes to the ankle level and check with the sonographic probe if we are not getting a proper reading. And usually the difference between upper limb and lower limb blood pressure, we know that is more than 20 millimeters of mercury. Anything else, sir, specific?
No, I was mostly looking at the practicalities of it in terms of whether we use a digital machine or a manual machine. If we use a manual machine, how do we use it? And then how do we compare up top? Because when you have, let's say, an ABI apparatus, then ABI apparatus is pretty good because you have got 4 cups which are measuring at the same time. But when you are doing it in the clinic, then how do you actually do it? Because I struggle checking leg blood pressures.
Clinic is sir, most of us, we don't have this ABI machine. We have to do it manually. So one upper limb and one lower limb at least we should check. That is what is practically possible in the OPD rush. So at least one upper limb and one lower limb blood pressure in a case of at least resistant hypertension should be done.
Perfect. Thank you so much, Prashant. Let me ask, and Prashant, by the way, you should check your chat box. Somebody is saying hello to you.
Okay.
And let me ask Vrinda. Vrinda, this patient, I hope you got the case summary right. This patient comes to you, let us say, from an endocrinology standpoint. Is it the right time, or is it does it trigger enough for you to look for endocrinopathies? And if it does trigger, how would you go about it? 55 male on 3 drugs whose blood pressure is still high.
Hi, everyone. Yes, I think, from an endocrine standpoint, prior studies with prior data that we had, we used to think that primary hyperaldosteronism is a rare cause of secondary hypertension. But I think as there was a recent article about it, I think published last year, which is now, improving our knowledge about this condition, that it may be more prevalent than actually what we think. So I think it will be a good time to actually investigate possible endocrine causes for hypertension, secondary hypertension. So I think the first and the foremost that would, the thing that would come to my mind is evaluation for primary hyperaldo. So, one of the key findings is hypokalemia on, laboratory workup. But, there are definitely patients who may have no normal potassium levels as well. So I think, for the medications this patient is on, I would not stop any medication, but I would still probably investigate, do 8 o'clock morning ambulatory plasma aldosterone level and plasma renin activity level. I would also investigate for hyperthyroidism, look for a TSH level. These are definitely things, more commonly that we can see in our day-to-day practice. Then Cushing's, looking for Cushing's disease. Now, definitely, like with Cushing's, patient's history physical examination may give you a hint, towards, the possibility of Cushing's excess cortisol. And then pheochromocytoma as well. So like whether the patient gives you a history of, sweating, diaphoresis, palpitations. So I think I would possibly look for these signs or symptoms in the patient as he walks in. And investigate for the same. I think my go-to would be definitely to evaluate for primary hyperaldo and do a TSH. And then the rest of the endocrine workup would essentially be based on the history and physical examination for this patient.
So before I let you go, the question often comes is these patients who are on 3 drugs, sometimes 4 drugs, whose blood pressure is uncontrolled. How do we interpret these endocrine values, these hormonal values? Because we know that a lot of these drugs, they do interact with the lab assessment. And then the whole question of random labs versus a 24-hour labs. So for a physician and a cardiologist, how should we interpret these things?
So, we do have to, weigh in it's definitely better that, if there was a clean slate that we could erase all the medications and then start afresh. But, a lot of times we have to weigh in the risk of stopping these medications and then doing the testing. So the bottom line is that, if the patient is on, say, an ACE or an ARB, I would still, I usually will not stop these medications. I would still go ahead and do the spot morning seated ambulatory 8 o'clock plasma aldosterone and renin activity level. Now, if the patient is on these drugs, technically they should, the plasma renin level, the concentration of these patients should come out to be elevated compared to it will be suppressed for patients with primary hyperaldo. So, if the case is that that you obtain these numbers and the plasma renin activity or the concentration level is still low, less than 1, so then there is a high possibility, coupled with plasma aldosterone values more than 20 or more than 25. So then you are entertaining a very significantly high possibility of entertaining a diagnosis of primary hyperaldo. So the case becomes difficult where where the plasma renin activity level is above 1. So then yes, you are in a mix. Then you would of course say that let's try and see if we can wean him off the medications and then do testing. But a very good indicator is the plasma renin activity or plasma renin concentration level, that if it comes out to be less than 1 suppressed in patients while on these antihypertensive drugs, then it's a good not in a good way, but it is helping you, towards the possibility of primary hyperaldosteronism. And that too coupled with higher numbers of plasma aldosterone levels. So less than 10 of plasma aldosterone level, usually not, hyperaldo. But if it is more than especially more than 20, much higher numbers, then there is a good possibility that this is primary hyperaldo. With TSH, there is not much of an interference. And then the biggest, the biggest issue is the use of aldactone. So if the patient, spironolactone. So if the patient is on spironolactone, then the testing becomes definitely difficult. So for patients on aldactone or spironolactone, I will ask them to hold the medication at least for 4 to 6 weeks before proceeding with the testing.
Thank you so much. Praneeth, you have something to add?
Yeah, I have questions to Dr. Brinda. So we do see patients who are having hypertension. So my questions is, when is it that we should refer to the endocrinologist? We lost touch with these endocrine things, the suppressions and the investigations done. So
Right.
my intention is basically to manage his hypertension. So it would be
Right.
to start therapy, but as I said, because with evaluation, what is a good time to refer to you?
So any time is a good time, I think. Like I said, that I think earlier we used to, think that endocrine causes are rare causes, but I think any time we are struggling to control blood pressure for a medication for a patient, two or three drugs and still not controlled. If especially on the laboratory exam, like investigation, if we see hypokalemia, metabolic alkalosis, but again, not every patient will have hypokalemia, not every patient will demonstrate metabolic alkalosis, but I think endocrine evaluation for hypertension should be, I think it should be in the thought process if we see a patient not controlled, 2 or 3 drugs, because like I said, we are increasingly being aware of the fact that, it is primary hyperaldo is more common than what we think. So I would say hypokalemia as a telltale sign. If you have a patient with hypertension, uncontrolled with hypokalemia, that's a good time to send to endocrinologist.
Praneeth, any other questions you have about the case discussion that we are having?
No.
No.
And then I think, Dr. Anup, you asked me about the 24-hour urine studies. So just a word on that, 24-hour urine studies are not an absolute necessity. So I think a good sample, like, collected at 8 o'clock spot, will give us a hint. And then if like we are suspicious based on the spot blood or the urine collection, I think we should investigate it further with a confirmatory testing, which is basically the salt loading test. So 24-hour urine studies are not an absolute necessity for evaluation.
Perfect. Thank you so much. Anybody has any other questions and comments before I move further? Okay. We have Chandramukhi ma'am here. Let me take one last opinion and then I'll move to Somaraju sir. Chandramukhi ma'am, we are discussing this case, which is a 54-year-old banker male who is having suboptimal BP control on 3 drugs, which are telmisartan, hydrochlorothiazide, and cilnidipine. And we talked about compliance, we talked about checking for OSA, we talked about doing renal artery Doppler, checking both the limbs blood pressure, advising him not to drink or smoke. Anything else that you think we should be doing or what you would do in your OPD? And secondly, I'm still perplexed with this lower extremity BP check. Have you ever done in your OPD? If you do, how do you do it? You do a digital machine, you do a manual machine. How do you handle this particular case and lower extremity blood pressure? Chandramukhi ma'am.
Thank you, Anu. Good evening, all. Yeah, lower limb BP, usually in young hypertensives, when they come with like newly diagnosed hypertension, then I make it a point to check the BP in all the 4 limbs. So lower limb BP now, because of the digital apparatus, it has become convenient to check the BP in the lower limbs. So I do it by using the digital sphygmomanometer. And like in this patient, he's having a resistant hypertension. So as already has been mentioned, the causes of the resistant hypertension should be ruled out, like OSA, renal artery stenosis, and I think hyperaldosteronism has also been discussed. So these things I would like to rule out. And in young hypertensives, it is also important to rule out coarctation of aorta.
And ma'am, when you talk about lower limb BP, you are talking about doing a calf blood pressure, I'm guessing, right?
Yeah. Ideally, it should be.
And if you could.
Yes.
Sorry, go ahead. Ideally, it should be. Sorry.
Like we should check the blood pressure at the popliteal arteries, but it is many of the times it becomes inconvenient, and then now checking the this BP at the calf of the lower limb with the help of the digital apparatus, it has become convenient and it is reliable also. So we are doing it now with the help of the digital BP machines.
And ma'am, if you could just share your thought with our audience about why are we checking the lower limb blood pressure? Like what particularly are we looking at?
Especially in young hypertensives, we need to rule out coarctation of aorta. So in these cases, I check BP of the lower limbs also, and in patients with Takayasu arteritis, aorta arteritis with hypertension also, it is important to check the BP in the lower limbs to rule out the middle aortic syndrome.
And the premise is that the blood pressure you will find there will be much lower than the upper limb blood pressure, and that would suggest that you have got a middle aorta, right?
Yeah.
Okay, all right. Okay, so I think we had at least 5-6 viewpoints on how to handle these cases. Somaraju sir, you heard all of us talking about this. If you could just share your thoughts on patients like these and all the practical aspects that we talked about, particularly checking lower extremity blood pressure, role of sleep apnea test, how do we do it? How do you address this to your patients and your teachings to the residents or junior doctors like us? If you could just share in the next 5-7 minutes your thoughts on these cases. Somaraju sir.
No, thank you very much. And I am not in a position to teach you. You are in a position to teach many of us, and I learned a lot of things in the whole discussion. While I say this, I must tell you, amongst the drugs that your patient is receiving, only chlorothalidone is 24-hour acting. The other two drugs are not 24-hour acting. So before you extensively study this patient, try to change the telmisartan to twice-a-day dosage or choose some other drug which is 24-hour acting, including cilindipine. Change over to long-acting preparation like nifedipine, long-acting, etc. before you extensively study this patient. So that sometimes takes care of these things. And other issue is I have to bring out the issue of the mistaken ideas about many of us who went through managing hypertension and importance of primary aldosteronism as an important condition in our routine practice. So over a period of years, we realized that it is more common than we realized. And then while investigation and confirmation, Dr. Brenda already mentioned, it's not easy. Just before you do extensive biochemical, because almost all antihypertensive agents interfere with those biochemical values that you do for say, investigation of primary aldosteronism. And hypokalemia is not essential. Earlier, the saying was that unprovoked hypokalemia, even provoked hypokalemia is important to keep in mind. Then I realized in my own practice and experience of others that just adding, before you do anything else, the patient's situation allows it and it's possible to do, just do an imaging of adrenals for a mass before you do extensive biochemical testing. That's easier actually. Then it makes it easier for you to investigate further. And hyperplasia is another issue, and it may not always be just a mass in one place. They just, I realized in our own practice that just adding the 25 milligram of say spironolactone brought down the blood pressure in a lot of patients, and they are well controlled. And but before I do anything else, I'll add increased telmisartan to twice-a-day dose or longer-acting calcium blocker before I investigate this patient further. And then some of the other issues are already answered about sleep study and all that. And many of you already talked about it. And if there is no, say when you gave all these medications, blood pressures are not controlled. And a 24-hour recording of blood pressure is extremely important. And ambulatory blood pressure, lack of nighttime dipping, sometimes may be the only clue to obstructive sleep apnea and some other conditions you are talking about. So such of these patients may still have to be investigated. As Praneeth mentioned already, absence of, say, snoring doesn't rule out, say, sleep apnea. And even snoring, you must talk to sleeping partner. Most often it is wife. You must be willing to call her at home or any other one he sleeps with. Some people don't sleep with anyone else. That will be the difficulty. And absence of snoring doesn't rule out sleep apnea. As somebody already pointed out, obesity is not essential for sleep apnea in Indian and Asian communities. And many other issues are already discussed. I'll leave it here. Thank you.
Thank you so much, sir, for your comments. Anybody else has got anything to add about this particular topic? While you gather your thought, I'll tell you, because every time I try to rationalize why I choose a particular topic and then give my 2 cents onto this. So one of the reasons why we are discussing resistant hypertension is because of, in the last decade or so, our evolving understanding that hyperaldosteronism, either primary or acquired, is more common than we think. And recent analysis even suggesting that it may be as common as 30% of general population. We are not talking about hypertensive cases. We are talking about general population that hyperaldosteronism or higher than what we think is a normal value could be present in as much as 30%, which may not manifest as hypertension in all of them, but certainly in patients with hypertension, it contributes to a large proportion. And that is where spironolactone, being the 4th or the 5th drug, is slowly creeping up to become maybe the 3rd or even the 2nd drug that we choose when we treat in patients into the so-called essential hypertension realm, where we think we are dealing with essential hypertension, but in a sense, what we may be dealing with is an undiagnosed primary hyperaldo, which is, as we're trying to understand, is far more commoner. And I certainly, last 2 years, have started taking it to my clinical practice, where I started adding spironolactone sooner in the management ladder as compared to waiting for 3 or 4 drugs to fail before I end up doing. A few things what I have also noticed and read about is to what you call to get that night dipping pattern in patients whose blood pressure is uncontrolled. So patients, as we know, normally we are all night dippers, which means our blood pressure drops during the night. And patients who lose this circadian rhythm, they tend to run higher blood pressure during the daytime. So if we can achieve this night dipping pattern, which can very easily be demonstrated by doing an ambulatory BP recording, and more so trying to keep some of the blood pressure medication at night, particularly those medications which inhibit the renal aldosterone antagonist axis, something like ACE inhibitors, ARBs, or your mineralocorticoid receptor antagonists, giving these medications towards the nighttime kind of help us achieve that nighttime dipping pattern. That also sometimes restores the daytime blood pressure, which is now kind of more into a recognizing pattern. Other thing which I also want to mention is, this is something we didn't discuss. I was surprised we didn't discuss this, is the role of exercise in achieving blood pressure. This patient is a bank, doesn't have any dedicated exercise regimen in his life. And there is enough data to say that exercise, particularly aerobic exercises, they are very helpful in reducing blood pressure, particularly diastolic blood pressure. It is very helpful. And the general recommendation is doing about 30 minutes of moderate intensity daily exercise, or 150 minutes of weekly exercise. That also helps reducing blood pressure a little bit. Cup size is very important, which is also what I often realize, that patients, they are using a smaller 32 centimeter cuff as compared to what they should be using, which is a 42 centimeter cuff, which sometimes gives them erroneously high blood pressure reading. And sometimes we are at fault as well, where the patients come to our clinic and we use the same standard cuff, which at times is not fitting them quite well. This happens more commonly in digital blood pressure machines, because in manual we have a long cuff, which anyway we wrap it around. So that is equally fine. I do think we take this opportunity to talk about alcohol and smoking, although I necessarily have not particularly witnessed blood pressure fluctuation that much with alcohol and smoking, but it's a good opportunity for us to talk to them about this. At the same time, I have also noticed, and I have read about it as well, that while this is an opportunity for us to address sleep apnea and treat sleep apnea, and these patients do subjectively feel better, how much if it actually helps achieving the blood pressure, that is also debatable. The best of the data suggests that systolic blood pressure goes down by 2 to 4 millimeters, but that too is highly debatable. But certainly this becomes a platform for us to address the role of sleep apnea, which helps them symptomatically and prevents long-term dreaded complications of untreated sleep apnea like heart failure and pulmonary hypertension in the long run. So that is also something that we should talk about. One common problem that does occur is when we try to institute aldactone in these patients, spironolactone in these patients, and if their potassium is running slightly higher, like something like a 4.8 or 4.9, because you're already giving them ARBs or ACE inhibitors, then it becomes a little bit challenging to add mineralocorticoid antagonist in these patients. And I often find questioning myself whether it is safe to put them on medication or not. This is one thing I will again invite maybe a question from the attendees about what do you do?
Anup, that is simple.
Yes, sir.
Try to give
Yes,
them
sir.
chlorothalidone plus this. Chlorothalidone smaller dose and aldactone. And that will take care of the pressure.
Perfect, perfect. So yeah, I try not to be very scared of it. I still give them spironolactone. They are getting hydrochlorothiazide or chlorothalidone. If they are not, I do add on to it. I do check their potassium after 2-3 weeks, but to me, a potassium of 4.8 does not preclude me from starting them on spironolactone. But this is another common thing that we see in our clinical practice. Praneeth, what do you think? Do you think potassium of 4.8, they are already very high, so the chances are they are not having primary hyperaldo? And if you think they do, you think there's a problem with starting spironolactone in these cases?
No, the issue of primary hyperaldosteronism I'm learning right now. So far, my knowledge or awareness on this entity is less. Regarding the point of starting spironolactone with a potassium 4.8, I would be starting them cautiously, provided I'm in a position to monitor them. Someone who is coming from districts, etc., I would be hesitant versus someone who understands and who can give me a feedback of checking their potassium after a few days. I would be cautiously starting them.
Yeah, I think, that district thing you mentioned, this is very important. In the last 3 years, I have had at least 2 patients who were in their villages, and they reach out to me over the phone, and I tell them to routinely check a potassium. And I remember at least in 2 situations, their potassium came more than 6, and I was not in a position to offer them very good help. So they ended up rushing to the nearest hospital, which at times was about 100 kilometers or so, only to find out that their potassium is indeed very high, and they ended up in the hospital. So I do understand that, sometimes the district patients, it imposes challenge in that particular regard. About resistant hypertension, anybody has any other discussing points, questions, or comments that we can address? I think we kind of covered most of what we typically do in our practical life. Lower limb blood pressure, I asked every person about this because this is something I struggle. I have checked calf pressures, but I will tell you my cheat sheet. I sometimes send an ABI. Sometimes I just order an ABI, let them go get an ABI done. I know that those blood pressure recordings are far more accurate than what I would do.
Anup, can I add something on lower limb blood pressure?
Yes, sir. Yes, sir. Yes, sir, please.
You're talking about the type of patient you are talking about 55-year-old person and above 55. And if the dorsalis pedis pulse is well felt, this patient doesn't have any symptoms of leg ischemia, you have no bruise or femorals or abdomen, the lower limb blood pressure doesn't help in the routine management, and it's not essential. But I also agree with you, ankle brachial index. But be aware, ankle brachial index and other issues are sometimes not reliable also when they have calcified arteries, particularly in diabetics, etc. Be aware of these things. But the most important thing is their dorsalis pedis is well fed, they are asymptomatic. Don't waste too much time on worrying about lower limb blood pressure. In this age group.
Absolutely, sir. Point well taken. A 55-year-old male who is hypertensive for 10 years, otherwise okay, not complaining of claudication with a good distal pulse. I agree. I think that we can leave it at that. There is no doubts about it. But then what Chandramukhi madam was saying, that once a while you do get those patients. So it is important to select ourselves in terms of which patients require what kind of workup. And it is good to know where all we can get help. So either we can do blood pressure check ourselves, or we can have an ABI check their blood pressure. So there, I don't particularly look at the ABI number. I just look at their blood pressure, because they report high pressure and they report calf pressure. So I'm able to use those blood pressure as a surrogate marker to see what happens. Certainly, as what you said, is in a 55-year-old, it may not make too much sense to dig into that much. On the other hand, their drugs, their compliance, their salt, their exercise, sleep apnea, atherosclerotic renal artery disease, all those things become far more relevant in this particular setup. Thank you, sir. Is there any other comment or question about this particular topic that we are discussing? If not, then I would ask Praneeth to give his closing remarks, and then we'll close the session for today. Praneeth, your closing remarks for
this.
Yes.
Anup, can I say something?
Yes, sir. Please go ahead, sir.
I heard you in the initial part of the discussions about number of people attending, and you're getting slightly concerned about it. But be aware, we have a serious problem in healthcare. The problem of knowledge management in healthcare and educating ourselves is a serious issue across the healthcare systems. It's not doctors and nurses alone, but even amongst doctors, and the most difficult people to transform and asking them to change themselves is doctors themselves. Don't be disappointed. And I used to say in teaching students for the last 40 years or more, that even if a half student attends, you should take the class. Half student by definition is the one who comes but sleeps in your class. So all the best.
Thank you so much, sir. This is our 37th session, and I promise you we'll complete 100, and then we'll go beyond that as well. We have not missed a single Wednesday since we started, except the New Year time. So we intend to continue, and I take your words. Even if half people are there, we'll continue that. Praneeth will be there, so at least there will be one person for sure. Praneeth, your closing comments, and then we'll close the session.
Yeah, so thanks for the encouragement, sir. So yes, today's topic was again good, one of the commonly seen scenario about evaluation of resistant hypertension. So the carry home points are about the appreciation of the increased prevalence of hyperaldosteronism and probable association with an endocrinologist working out and evaluating, and probably considering the mineralocorticoid receptor antagonist is one of the earlier therapies for managing resistant hypertension. Also highlighting the importance of obstructive sleep apnea syndrome, which is again missed or underrepresented, which also needs to be considered, and the practical considerations of what drugs they are taking, how they are taking, frequency of administration, and other confounding factors which can lead to falsely high blood pressure readings. And lastly, the importance of measuring the accurate blood pressure cannot be overemphasized. So this would be the carry home messages that I could get from today's session.
Thank you, Praneeth. Thank you all for attending today's session. I have one last comment from Dr. Prashant. He writes, Considering he's a banker, a beta blocker may help his sympathetic nervous system, and I think that's a very reasonable statement. Also, that telmisartan is not on a full dose. I agree with that as well. Telmisartan, the full dose is 80 milligrams. Although my only comment to that is when you look at the incremental benefit of any antihypertensive, not just telmisartan, any antihypertensive, when you go from moderate to high dose, then their additive antihypertensive effect is not much. Having said that, there is no harm in trying a full dose antihypertensive drug, but keep that in mind that your incremental benefit may not be that much. So anyway, I would like to close the session. To the attendees, would like to get feedback. If you found the session worthwhile, may we request you to share it amongst your colleagues. Since the general motive is thought sharing, and more the people join, more thoughts we will be able to share. We host this session every Wednesday at 7:30. We typically run 2-3 minutes late, but not more than that. And the link to join is the same that you used today. So it's a static link. You can click the same link in case if you don't get an invitation for the next time. By the way, you should get it. But if you don't, just click on the same next Wednesday at 7:30. And I promise you we'll be on here with another topic. Thank you again for participating. Good night, and I hope to see you all next Wednesday. Take care, guys. Thank you.